everyone on YouTube, sorry for this. There is a little bit of a last minute glitch. Please stay with us. In the meanwhile, why don't all of you just start saying your name and let everyone know who's taking part while I bring our judges in?
Hello, I'm Dr. Sonal Jerpude. I'm the first speaker for the day. And this is my first open mic session with ma'am also. And I'm enjoying this whole feel of oral pathology 360. And thank you for having me, ma'am.
Thank you so much for being here.
Hi, good afternoon, everyone. I am Dr. Amit Chavla from Gurgaon. It's wonderful meeting you all here. And all the best to all of you.
Yes. Thank you, everybody, for that. Hello, Professor Hiller, and hello, Dr. Anshu Chowdhury. Our first two attendees have arrived. In the meanwhile, I have to also, before we go any further, I have to share the link for people to be able to vote. So let me do that, and then we are good to go. Right. So everybody, that is the link from the website where you will be able to vote as we go on. It is on the page, the event page. And if you just scroll down a little bit on that page, you will find the whole poll. You can vote for as many as you want. So first and foremost, thank you, Dr. Yoitab, you made it. Let me just, and I can see Dr. Nagpal also is here. And Dr. Akinshipo also made it last minute. So everybody is here. The little delay had its own advantages. So anyway, we are back. We are connected. Everyone is here. We are all mighty excited. This is a very exciting event among the many things that Oral Pathology 360 does, because of the fact that it brings people from around the world and around different disciplines and doing different things in an entirely open platform where anyone who has registered has a chance to come and speak to you. It's a great opportunity, and we are very proud and very privileged to have been able to bring you this opportunity. So, Oral Pathology 360, because I realize some people will be joining us today for the first time. So, Oral Pathology 360 is a non-profit. I'm the founder, I'm Dr. Mandana Donahue. The whole idea is to bring forth the disciplines that run the management and the diagnosis of the oral and maxillofacial diseases in the forefront. We are just trying to promote these sciences. We are trying to interact with everybody, improve our education, improve public awareness, and of course, collaborate across the board. That is as far as Oral Pathology 360 goes. And if you're here on the channel the first time, do definitely remember to subscribe. As far as what today is going to be, well, we have contestants who are all faculty. Basically, they are not students. So whether in college or whether in private practice or in research or whatever they are doing, they are not students. And we have some basic rules which I will share, both for them and for the audience, since you are going to be voting eventually. So one of the main things is to follow the time limit of 5 minutes. These are the rules for the contestants. And this is to ensure everybody gets the same opportunity. The next one is, in the allotted time of 5 minutes, you will introduce yourself and the title of your presentation, share your slides if you're using them, although it is not essential, and then you should ensure your camera is off and muted for the rest of the time. That would be great. And for the audience, now your vote will be helping us decide the winner. And for that, you need to use your email ID and your name. I have already shared the link in the live chat. That is where you will be voting from. And the voting will start from 3 o'clock. So it is already on. But please do wait till they start the presentations before you vote, of course. So the link I've given you, all the names are given on the website in that form, one after the other. You just have to, it's a checklist, but you can choose multiple. Each vote that each person gets is one vote, is one count. And eventually also you can, if you're watching us, you can share the link of this video with anyone else who is interested and who would be able to vote. The results will be announced tomorrow through our many channels on social media using our regular handle, which is at Oral Pathology 360, and also here as a community post on our YouTube channel. It will also be on our WhatsApp channel. Actually, we have channels everywhere. If you follow us anywhere tomorrow, you will find the results. The decision will be based on a combination of the judgment by Dr. Bhuvan Nagpal and Dr. Yuita, and that the grading they give is up to 50%. Another 50% of the overall grading is what will be by the audience vote. So whatever votes we receive, we are going to turn it into 50%, turn it out of 50, and then the two combined will give us the winners. To just highlight and remind everybody what the prize is, well, the three top presenters will, of course, receive certificates. The best presenter, or that is the winner, will be given an opportunity to present a lecture on our very prestigious Oral Pathology Tuesdays on a topic of their choice. And the winner will also be eligible to compete with two other winners of open mic faculty that will be held in November and in Feb. These three winners will eventually stand off against each other to win the Rising Star guest speaker spot in the International Oral Diseases Case Presentation Conference 25, which will be in May, which will be our fourth conference. It's a very large conference with people attending from around the world. Over 50 countries normally attend. So it is very prestigious and it's quite big. Our last year's winner is one of the judges, Dr. Yoitab. Yes, he also presented a marvelous lecture at the conference. So he is right here. He literally feels what you feel. So that is why he is one of the judges. Right. With that, I think I have completed, except now I will also introduce the judges properly. Dr. Yoita Prabhunath, who, as I was saying, was the rising star of last year. And he's a professor in Department of Oral and Maxillofacial Pathology, Vivekananda Dental College for Women, Tamil Nadu, India. He is skilled in public speaking and leadership, besides, of course, many other things that he does. Then we have Dr. Bhuvan Nagpal with us. He is a career oral pathologist in the true sense and the founder president of Practicing Oral Pathologists and Microbiologists Association, fondly known as POPMA, that has become a game changer in the practice of oral pathology. He is with us today for his ability at public speaking and influencing professional and public perception through his work. So, those were our two judges, and we are all set to go with our first. Now, I will request everyone else to turn off their cameras and their mic, and I request Dr. Sonal Yerpudi to please start her share.
Ma'am, is my screen visible?
Yes, it is.
Okay. Hello, everyone. I'm Dr. Sonal Yerpude. I'm a private practitioner, in fact, a general practitioner from Thane. For the past 20 years, I have been dealing extensively in full mouth rehabilitation cases and management of chronic pain cases. So before I begin, I know I'm not an oral pathologist, but one thing for sure, what I'm going to be talking to you all will be a story, something will definitely click with you all, wherein you will be able to recognize these conditions in each and every patient or yourselves also. So let's begin. Excuse me, ma'am, sorry. Yeah, I believe every smile has a story. Have you ever wondered that you can have a pain-free condition, a change in your thought process, or some change in your lifestyle, which can bring about a 360-degree change in yourself also? So here I have a story for you all of a 22-year-old female who came into my practice complaining that for the past 6 years, she was having pain while swallowing, pain while difficulty while breathing, continuous dull bilateral pain in TMJ and jaw, neck and muscle pains, disturbed sleep pattern, chronic fatigue, mood swings and depression. We also found out that she had the vitamin D3, B12 deficiencies, and she was anemic also. What are the factors that led for this painful condition to get more worse was the psychological negative thought process that she carried in her, that I will never be able to come out of this whole negative cascade. She was mystery hunting with doctors here and there without any help. Her negative emotions became depression, so much so that she self-doubted herself. Her behavior changed. She became more guarded of her behavior pattern, guiding in a way that she used to become underactive or overactive in her behavioral pattern. And socially also, her friends and family were over-responsive at times, or at times they ignored her symptoms. This led to a chronic pain cycle wherein the anxiety crept in, and that led to brain focusing only on the major aspect, the pain, and that changed her nervous system in a way that she felt pain cycles more. This led to the interdependencies and the havoc that thought process, emotions, and behavior brought about in her. So now why CBT? What CBT will help us with doing with these cases? We as dentists, we are trained to treat these patients, but how CBT will work as an adjunct in therapy with all the other essential therapeutic systems we are using. CBT is basically focuses on managing cognitive and behavioral changes to disrupt the problematic cycle, thoughts, feelings, behavior, and bring about a change in the challenging, unhelpful thought pattern of the patient. We may not be able to get rid of this pain entirely, but definitely we will change the pattern in which the person thinks about it. Definitely, it will also help us in managing chronic pain patients who have cancer-related pains or any mucositis-related pains or any other pathological pains. They will be accepting the treatment better. The phobia will be reduced. Now, this is a testimonial of the patient who walked into my practice. I will show you all what changes this patient has undergone in 2 weeks of therapy.
I'm doing good. So how is the pain now? Pain is reduced a lot. It's a lot lesser pain in these regions. Okay. Just a little pain here. Okay. What about your swallowing pain? You used to complain about pain while swallowing. I don't have pain while swallowing now. Breathing is also much easier now. I feel like my airways are more open now. And whenever I do the exercises, it's lesser pain and I can breathe easier. I'm sleeping much better. Most of the days I wake up feeling rested. Some nights I still struggle, but that's okay. It's still manageable.
Have you ever wondered that if there is a proven method to regain control of your thought and emotions leading to a happier lifestyle? And this is what exactly happened in this patient. We are still monitoring her vitamin D3 and B12 deficiencies and covering up her anemic condition. So what, as a CBT consultant, we practice more on engaging the patients with behavioral changes, restricting their movements, distraction techniques, stress management also, and some of the behavioral strategies. What are the pros and cons of CBT? The most important pros, I would say, for cognitive behavioral therapy is that it is non-invasive and patients can actively get involved in it. It works along with, it works very good as an adjunct to drug therapy. And the most important cons, I would say, is that you have to be very thorough with your case selection. Be very
Dr. Sonal, time is up.
Okay, be very diligent while selecting the case. Thank you, ma'am.
Welcome. So for everyone who is voting, that was our first presenter, Dr. Sonal Yerpudi. Right. We can move on to our second presenter. That is Dr. Amit Chawla. I can request everyone else to turn off their camera and their mic. Yes, Dr. Amit, you're ready?
Yeah, I'm ready, ma'am.
Yes, you can start.
Hi, good afternoon, everyone. I'm Dr. Amit Chawla, practicing in Gurgaon since last 15 years. The title of my presentation would be today is What Dentists Aren't Taught in a Dental School. Let me start by saying this. Are we just the dentist or business owners as well? Yes, we are both. So let us talk some business today. Every day, whenever we go to our work, we do two things. One of which is something we were taught in a dental school and other we didn't. The one which we were taught was how to practice dentistry, and what we were not taught was how to run a business. It's an entirely different animal, I must say, after 15 years of my practice. So let us imagine a typical day in a dental office. You are working tirelessly throughout the day, and you had planned your appointments already. But suddenly there is a last minute change in one of the appointment, which rolls down to the next one and the next one. Now you are having a throbbing back pain, and now the sweat is rolling down through your forehead. Suddenly you remember that you had to attend your son's school ball game program today, which you are gonna miss today. This is a typical recipe for a burnout, which we need to change if we want to build a practice we dream. For this, we need to implement certain things into our practice. Number one, effective practice management. We should implement digital marketing, digital practice management tools such as softwares, applications, so that we can manage our appointments accordingly. We should also give enough space between two appointments to avoid a last minute catastrophe. There is also another way of doing it by calculating the value of time. Suppose if I work 35 hours a week and I earn 35,000 rupees a week, then my per hourly rate is 1,000 rupees. Anything which is costing me less than my per hourly rate, I should outsource that thing. That's how you can manage your time. Number two is staff management. We should always hire extremely skilled and highly efficient staff so that everyone in the practice is aligned to a common goal. We should always make it a point to keep them up to date with latest digital or other dental technologies. Number three is financial management, which is the most critical thing. We should allocate costs to different areas of our practice based on proper ROI analysis. We should not just keep buying every new instrument or gadget coming into the market because everything is just not meant to buy. We should also implement some patient retention programs like subscription plans and loyalty programs. Number four is patient experiences. We should always make it a point to keep increasing patient experiences through a strong feedback system, or maybe through call, WhatsApp group, or Facebook or Instagram page. Number five is to build marketing strategies, which includes digital marketing practices. Again, going in for some website optimization or through social media engagements such as Facebook or Instagram. We should keep posting information such as dental tips, patient stories, testimonials without asking anything in return. Number six is to regularly organize workshops like corporate events and school dental health education programs. Number seven is monitoring our own practice strategies. We should continuously keep monitoring our strategies so that to find loopholes into it and modify if needed. In the end, I would like to say that we should all make it an effort to continuously and regularly keep attending conferences, seminars, and workshops like this one to regularly upgrade our knowledge and to increase our networking opportunities. So that was all from my side. Thank you and have a nice day.
Thank you. Perfect timing also. Yes. Two presentations down and it's going very, very well. We go on with the next one. Just to remind everybody who would like to vote, the link now I have pinned it as the comment. That is, the link is pinned to the chat, to the top of the chat. You can go to that link. Otherwise, you can just go to our website, oralpathology360.com, look at the tabs, go to events, and then find today's event, and just it's on the event page. Right. So let's go with the next presenter. So our next presenter is Dr. Shivani Mongala. Yes, Dr. Shivani, you're ready?
Yes, ma'am.
You can start.
Yes. Hello, everyone. The topic of my presentation is A Coin Has Two Sides, Oral Pathology. I'm Dr. Shivani, recent oral pathology graduate and assistant professor in a dental college. Let's start with a scenario. You, your junior or senior, gets a seat in the oral pathology. What's your reaction? Who does PG in oral pathology? What's the future? And you joined oral pathology because the fees was low, or the seats you didn't had any other options. Sound relatable, right? Don't worry. I was in the same boat 4 years ago because, like you, I was looking at the same side of the coin for the longer time. That is, either practicing as a general dentist or joining the academia seemed like the only options in the oral pathology. Less people we knew were practicing oral pathologists. All these are facts and the same side of the coin. Let you answer me at the end if you flip the coin, or is it worth flipping the coin if I'll tell you what's on the other side of the oral pathology? You can pursue fellowship in the head and neck pathology both in India as well as in the foreign country, where you can practice in a hospital. Next, you can do a fellowship in forensic odontology and help in solving the medical legal cases. You can learn tobacco cessation and counsel the patient in your own dental clinic as well as wherever you go as a consultant dentist. You can become a research associate in the prestigious organizations and institutes like ICMR, AIMS, etc. Join multinational companies as medical data analyst or medical data reviewer, where the knowledge of oncology is needed. You can set up your own dental clinic with a oral pathology lab, or else you can enroll yourself in the PhD programs. Oral pathology is not limited to diagnosing the oral disease and condition. It's a multifaceted branch which includes serology, clinical pathology, clinical biochemistry, hematology, molecular pathology, and microbiology. You have to choose a particular field to work on and do value-added courses and get a job in a hospital or in a lab. Wait, I'm not finished yet. The list is little longer because there are many unopened and undiscovered doors that we aren't aware of. The key is not to stop. Okay, do you agree that oral pathology often gets overshadowed by more traditional or mainstream dental careers? You know why? Because we fail or step down ourselves in introducing as oral pathologists. This might actually hinder the visibility of the oral pathology, which is proportional to the opportunities. So the other option includes be visible. I know you're visible, but I'm talking about professional visibility. Market yourself, make a visiting card mentioning MDS in oral pathology and microbiology. You can establish a oral cancer screening program in communities, corporate offices, as well as in your dental clinic, and ask your fellow dental professionals to join the initiative. You can actively attend dental as well as oral pathology conferences and conventions. Be active in presenting posters and papers, and also make sure that you meet professionals, discuss the future possibilities. You can join the active groups of the oral pathology like POPMA, that is Practicing Oral Pathologist and Microbiologist Association, where I am a member too. These people are actually helping, guiding, educating, and bringing the positive change towards the subject and the mindset. You can actually publish a papers in the journals. Apart from that, you can take a help of professional platforms like LinkedIn, where you can connect and collaborate with the seniors and the practitioners. And you can, lastly, you can use the technology where you can create a learning platform for the upcoming students. I know the fact it's easy to list out the trends, but trust me, it is more important and it is actually on you when you work on it, because we are the creators shaping the path of the oral pathology forward, and it's the future generation who's going to follow us and embark the future of the oral pathology. As a fellow oral pathologist, I would like to say no, it's not easy. Yes, you have to face rejections multiple times, and trust me, you have to trust the timings and not to give up. The passion for this subject has to keep you motivated, to do forward. It is clear that oral pathology is not just a career path, but it has a rich potential for those who are willing to explore and innovate. To whoever listening, the question remains, will you flip the coin and explore the myriad possibilities? Indeed, oral pathology is vast, interesting, important subject with many aspects one can look towards. It is us who are looking on the same side of the coin and are missing out to flip the coin and explore the subject and opportunities. Yes, it takes efforts. Taking smaller steps at a time with constant dedication, knowledge, connection, passion, you can create a platform that will help. Most importantly, you
Dr.
must
Shivani, I'm
understand.
afraid you have finished your time.
Yeah, ma'am. I'm also done. It is importantly one must understand the importance of the oral pathology and stand on its side. Thank you.
Thank you so much, Dr. Shivani. Yes, we'll go on with the next. Dr. Priyanka, you're ready?
Yes, ma'am.
Okay, you can share.
Good afternoon. I'm Dr. Priyanka, and today I'll be talking about educating women warriors in the fight against HIV and AIDS. According to UNAIDS global data, as of 2023, around 40 million people are living with HIV, and among them, 53% are women and children. Among new infections in 2023, 1.3 million people were newly infected, among which 44% were women and children. In the Indian scenario, out of the 2.5 million estimated people living with HIV, 1 million are contributed by women. WHO selects the young people in the age group of 15 to 24 as being the epicenter of this epidemic. In India, currently 150,000 young people are living with HIV. This increase in the number of HIV among women and girls are due to certain biological and socio-economic norms which are critical to the context of HIV. This increase is due to certain social norms such as women are not supposed to be sexually knowledgeable due to unequal power relations, poor access to information, health sciences, education, lower priority on their health, and lack of decision-making powers within the family. These critical reasons heighten the vulnerability among women and weakens their ability to protect themselves and negotiate for safer sex. Empowering them with knowledge is the key to behavioral change, which is the key in controlling this epidemic. This knowledge comes under the title of Comprehensive Knowledge of HIV and AIDS, wherein women are given knowledge regarding prevention of HIV. For example, consistent use of condoms during sexual intercourse, engaging exclusively with an uninfected sexual partner reduces the chance of having HIV. They should also know that a healthy-looking person can have HIV. This knowledge also has to reject two common misconceptions about the transmission and prevention of virus. That is, HIV can be transmitted through mosquito bites, sharing food, utensil, clothes, or toilets with an already infected person. These two will not cause HIV. According to the fourth round of National Family Health Survey, only 21% of Indian women in the age range of 15 to 49 years had comprehensive knowledge of HIV. The survey also told us that education, household wealth, access to mass media, and having tested for HIV with access to HIV counseling and testing centers were the significant determinants for this comprehensive knowledge among women. The National AIDS Control Program lays maximum emphasis on information, education, and communication for prevention of HIV and AIDS. In spite of this, the percentage of knowledge among women regarding prevention of HIV and AIDS is insufficient. So policymakers and public health practitioners should plan in such a way that the information gap that exists among women should be closed. Discussions in public forums during cultural and religious events via public service announcements and media campaigns will go a long way in dispelling the myths and disinformation regarding HIV and AIDS. Lastly, community education, community wealth, and community employment have a significant role to play in delivering this knowledge to the women. To conclude, as the saying goes, if the lady of the house is educated, the whole family is educated. Empowering women is one of the first and foremost step in the fight against AIDS. Culturally, HIV/AIDS is still a taboo and talking about them freely is still not possible. As women, it becomes imperative to find means of gaining knowledge about AIDS for the well-being of not only the lady of the house, but also the whole family. An adolescent girl with an educated and an empowered mother has a better option of saying no to any means by which AIDS can be spread. Together, let's unite in the fight against AIDS. Thank you.
Very nice. Thank you.
Thank you, ma'am.
And We go with our next presentation. That is Dr. Sweta Acharya.
Greetings from JSS Dental College. Myself, Dr. Shweta Acharya, a full-time research scholar in JSS Dental College in the Department of Oral Pathology. I'll be speaking about persistently troubling tales of traumatic tongue ulcers. Ulcer is defined as a break or discontinuity in the epithelium or that is a break in the bodily membrane, which results in the impediment of the affected organ. Robbins defines ulcer as a breach in the continuity of epithelium mucous membrane, which is caused by sloughing out of the inflamed necrotic tissue. Oral ulcers are common lesion, which is precipitated by several underlying factors. Traumatic ulcers are the most frequent one, and usually predominantly they affect buccal mucosa, tongue, as well as the lip. These can be precipitated by physical, chemical, or thermal injuries or sources. Whereas dental problems such as sharp tooth, broken restoration, or a clasp of a denture can induce a traumatic ulcer. Here is a case of a chronic tongue ulcer, which is precipitated by a sharp tooth. An innocuous appearing ulcer on histopathology was showing the features of a squamous cell carcinoma. So, when evaluating a solitary tongue ulcer, differential diagnosis encompass a variety of entities and conditions, like which is including traumatic ulceration, giant aphthous ulcer, or eosinophilic ulceration, or oral squamous cell carcinoma. The list goes on. So, the tongue lesions can be developmental in origin, traumatic, inflammatory, systemic conditions, or because of malignancy. So basically, many of the tongue pathologies or lesions are unique, which are being diagnosed as a rare entity. Basically, epidemiological studies show that globally, 18.5% of population being affected by the tongue lesions. In India, it is highlighted that in many studies that tongue is the second most prevalent site for the cancer. Here is a patient who came to us with a chronic tongue ulcer on the lateral border of the tongue. She gives a history of chronic microtrauma because of sharp edges, because of age-related changes. On histopathology, we could see the features of a squamous cell carcinoma. Basically, this chronic tongue ulcers presence on the lateral border of the tongue, especially in the middle and posterior one-third. They usually present as shallow ulcers, and usually these shallow ulcers are surrounded by rounded, elevated, rolled out borders and surrounded by an area of hardening or an induration, mimicking mimicking oral carcinoma, usually based on the location as well as the characteristics. So here is a patient who presented with an endophytic lesion, an ulcerative lesion, and he gives a history of a chronic microtrauma. And this was having a rolled out, everted, raised border with a surrounding area of induration. On histopathology, we could see that the dysplastic epithelium proliferating and destructing the underlying connective tissue, suggestive of a squamous cell carcinoma, well-differentiated squamous cell carcinoma. Sometimes chronic microtrauma on the lateral border of tongue can precipitate and leads to an ulceroproliferative lesions, as reported in these patients. Sometimes chronic microtrauma can also lead to chronic ulcers that have unique histological features, which is showing an infiltrative granulation tissue along with destructive inflammation dissecting deep downwards with dominance of eosinophils, which is suggestive of an eosinophilic ulcer. So basically, whenever there is an ulcer which is persisting and it is not healing spontaneously, it has to be subjected for a biopsy and histopathological examination, which is mandatory. So basically, chronic traumatic ulcers are challenging because it is very difficult to identify the triggering factors. If issues like broken cusp, that is broken cusp or a fractured restoration or a problematic clasp, which can be pinpointed and corrected, healing may ensue. Often, injuries result from impaired tongue coordination or because of enlarged tongue or poorly positioned posterior teeth on a denture base, which may contribute to the problem. Overall, managing chronic tongue ulcers requires a comprehensive management, considering both local and systemic factors contributing to their development. Accurate diagnosis and targeted treatment can lead to resolution of these challenging lesions and improve patients' overall health and quality of life. Thank you.
Perfect timing. Okay. Thank you, Dr. Swapna. Sorry. Yeah, Dr. Swapna, you are next.
A very good afternoon. I'm Dr. Swapna Amod Patankar, faculty in the Department of Oral and Maxillofacial Pathology and Oral Microbiology at Bharati Vidyapeeth, deemed to be University, Dental College and Hospital, Pune. Thank you, Dr. Mandana, for giving this scientific platform. Today, I'll be shedding light on the topic of the role of estrogen receptors in the oral cavity of women during the perimenopause and menopause. The presentation overview. During her lifetime, a woman experiences many hormonal fluctuations that affect her overall well-being. Perimenopause and menopause are natural stages in a woman's life. Very well said by Dr. Milheiser. Going through perimenopause, menopause, or a midlife change can be very challenging because it may disrupt your entire existence. And hence, I decided to choose this topic today for my discussion. Perimenopause is a transitional phase, which I call as a rocky road to menopause. It is seen in women in their early 40s or even in mid-30s. The body secretes less amount of estrogen. Menopause is a normal part of aging and marks the end of women's fertility. It is normally seen in women who are 45 and 55 years of age. The oral cavity is often considered as a reflection of the body's overall systemic health. Oral health means much more than healthy teeth. It's the relationship between oral and general health. The majority of pain and discomfort in the oral cavity during these two phases is due to decrease in estrogen levels. The oral mucosa and salivary glands contain estrogen receptors, and variation in the hormone levels can directly affect the oral cavity. These are the different phases of a woman's life which are affected by hormonal shifts, thus causing paucity of saliva, leading to xerostomia, increase in incidence of dental caries, taste alterations, chronic ulcers, gingivitis, periodontitis, bone loss, increased sensitivity, burning mouth syndrome, salivary gland tumors, and temporomandibular myofascial syndrome. It's a long, exhausting list. Thus, a woman's smile can hide so much pain. Let's see the role of estrogen receptors in salivary glands and oral mucosa. There are three types of receptors: ER alpha, beta, GPER1. ER beta is widely expressed in high levels in keratinocytes and salivary gland, acinar, and ductal cells. Estrogen may act via these receptors on oral tissues, and thus the effect of hormonal changes are seen on oral mucosa, salivary secretion, and composition. Overexpression of ER alpha, progesterone receptor, androgen receptor play a fundamental role in pathogenesis and progression in salivary gland tumors. Xerostomia can lead to dry lips, tongue, increase in dental caries, oral candidiasis, gingivitis, bleeding from the gums, and halitosis. It can also lead to a painful mouth because of decrease in salivary flow. High progesterone levels may cause oral mucosa to swell, may stimulate the growth of destructive bacteria, or may suppress the immune function. This will also hinder the collagen production, which reduces the tissue's ability to repair itself, thus leading to chronic ulcers. Gingiva shows atrophic gingivitis and gingivostomatitis. It will show recession, leading to sensitivity to cold. It progresses to periodontitis, leading to bone loss, teeth mobility, and teeth loss. Perimenopause, menopause also cause osteoporosis in the jaws, a silent disease. Loss of bone mass leading to fractures, pain, and loss of function. This is basically because of abnormal increase in resorption of the bone. Bone-forming osteoblast and bone-resorbing osteoclast express estrogen receptors. Thus, fluctuation in the estrogen levels leads to osteoporosis of the jaw and the jaw shrinkage. Temporomandibular joint also shows presence of estrogen receptors, the condyloid tissue of condyle and the retrodiscal tissues. Estrogen depletion leads to structural changes such as increase in cartilage thickness and degenerative changes with bone loss in the condyle, thus leading to clicking, popping, catching, locking in the jaws, headaches and earaches, and difficulty in opening mouth to eat and brush. Burning mouth syndrome is most commonly seen in perimenopausal women. It leads to burning and pain sensation in the oral mucosa in the absence of pathological lesions. What is the treatment for all these? It's the hormone replacement therapy, nutrient-rich diet, vitamin B, D, and calcium supplements, aromatherapies, regular exercise, and drinking ample amount of water. Thus, to conclude, a woman is most beautiful when she smiles. So let's be the reason to bring back the smile and help prevent the challenges of midlife. Thank you.
Thank you, Dr. Swapna. We go on
Thank you.
with our next participant, that is Dr. Abdul Warid Akinshipo. And before we go on, let me remind everybody that you can vote. In fact, you should vote by going to the link which is on the top of the chat. On the live chat, you find a pinned comment. That's the link you need to go to actually vote. And yes, your vote is going to decide who wins. So please make sure you go and put on your vote. You can vote for multiple speakers. In fact, that's the idea. You can share multiple names. You can, it's a multiple choice actually. So you can check as many speakers as you want. Keep it open because you can log into it only once with each email. Right, we have Dr. Akinshipo's presentation, I believe. Yes, you can start, Dr. Akinshipo.
Good morning, good afternoon. I'm presenting time to recurrence of ameloblastoma and associated factors in a multi-institutional Black patient cohort. It's part of the work that we presented in a published article. I'm Dr. Akinshipo Waris. I'm from the Department of Oral and Maxillofacial Pathology, Faculty of Dental Sciences, Lagos, Nigeria. So basically, these are the outline, and by way of introduction, ameloblastoma is a benign odontogenic neoplasm with an aggressive growth behavior, a high recurrence rate, and a potential to transform into a malignant neoplasm. The World Health Organization classified the benign types as conventional, unicystic, peripheral, and metastasizing ameloblastoma. Conventional ameloblastoma is the commonest type, comprising about 85% of all. It is associated with a high rate of recurrence. Studies have shown that those conventional ameloblastoma treated by curettage and enucleation have a recurrence of 55 to 90%, while those treated by standard surgical resection with adequate margin have a recurrence of 15 to 26%. So the aim of the study was to assess time lag between primary and recurrent ameloblastoma in a multi-institutional patient cohort and other factors associated with recurrence. So basically, it was a retrospective observational study, and cases between January 2010 and December 2022 were extracted from 4 of these institutions, 3 in Nigeria and 1 from the University of Pennsylvania, United States of America. So the outcome variables were time to recurrence, and the predictor variables were tumor type, age, gender, circumstance of recovery, that is whether the patient was discovered, presented with symptoms or not, and then the racial profile of the patient. Variables without detailed information were excluded from it. So the basic results that we want to share is the fact that we saw a total of 115 recurrent ameloblastoma. The patient cohort was predominantly a Black one, so we had 91.3%, but we had some 6% of Caucasian and 2% Hispanics. Conventional ameloblastoma was the commonest histologic type, comprising about 89.6%, and most of them occurred in the posterior mandible. So this is basically a table to show the association between the demographic profile and the median time to recurrence of ameloblastoma. We looked at 3 variables that were particularly significant in determining the recurrence. We looked at gender. The median time to recurrence between male and female was statistically significant. Males had recurrence in males occurred at 62 months, while the ones in females occurred at 90 months. We also looked at the age. So recurrence in the younger group occurred at 36 months, while recurrence in the older group occurred at 72 months. Also, the patients that presented with that were discovered on routine investigation, by just taking routine radiographic investigation, recurrence was discovered at 36 months, while those that already had recurrence and presented with symptoms, recurrence was observed at 75 months. So, by way of discussion, we're presenting here that recurrent ameloblastoma was seen in 91% of patients of African descent in this multi-center patient cohort. A systematic review reported a higher percentage of recurrent ameloblastoma in Afro descendants compared to non-Afro descendants. While impact of race is skewed in favor of Black patients in this current study, it is worthwhile to investigate the reasons for recurrence in Blacks. Socioeconomic factors and limited access to healthcare might discourage Black individuals from seeking treatment, which could lead to failure and loss to follow-up after resection of the primary ameloblastoma. We also looked at the identification of recurrence. By this, we're talking about symptomatic patients that presented in the clinic and those that were discovered on routine X-ray. So systematic patients had a significantly longer median time to recurrence compared to those that were discovered on routine evaluation. This suggests that a major advantage of adequate follow-up is early detection and prompt treatment of a recurrent tumor. Strict periodic radiographic screening during the first 5 years is highly recommended. We also looked at the gender difference. In spite of the fewer number of female patients in this cohort, the median time to recurrence was significantly longer in females than males, which indicates males may apparently present earlier than females for treatment. This could actually reflect a gender difference in attitudes to facial appearance. However, it could also reflect that maybe the females have reduced access to care, considering the climb that we're in. So, by way of conclusion, we demonstrated that males present sooner with recurrence. Younger people present sooner with their recurrence. And we also showed a significantly shorter time to discovery of recurrent ameloblastoma in patients with periodic follow-up when compared with patients that present with clinically symptomatic lesions. These are the references. Thank you.
Thank you, Dr. Akinshipo. That was a nice presentation. Now we go with our next presenter. Dr. Akinshipo, if you can stop sharing your screen, please. Our next presenter is Dr. Naveed Iqbal. Yes, I stopped the share. Okay. Dr. Naveed Iqbal.
Now you can see me. Good afternoon, everyone. My name is Naveed Iqbal, and I am presenting one case report regarding the management of oral lichen planus, which presented as a palatal erosion and desquamative gingivitis. So this is a case report about a female patient of 46 years of age. And as you all know that oral lichen planus is a chronic inflammatory disorder of unknown cause, and there are various presentations of the lichen planus. The most common is reticular pattern, and there are several other forms of lichen planus like bullous type, like erosive type, and they are classified according to their presentations. This case report is about a female patient of 46 years of age who presented with a 6 month history of a lesion on the palate, hard palate on the right side near the molar teeth. She also has desquamative gingivitis in multiple sites of the oral cavity. And she is otherwise normal, no habits, no medical history, nothing. Everything was normal with her. She reported about the pain and burning sensation on the palate. So I will show you the initial presentation of the lesion. That was the lesion initially presented about 4 months back. So there was a palatal erosion with atrophic area surrounded by white patch, which is extended to the soft palate, and there is desquamative gingivitis along the gingival margin of the molar teeth. Similarly, there are other sites affected by the desquamative gingivitis, like in the anterior lower gingiva and upper side also. So there are multiple gingivitis area which are affected by the lesions. So diagnostic approach was complete history, periodontal and clinical examination. Also, I did OPG and CBCT to locate any bony invasion, anything else. So clinically, I make a differential diagnosis, which included the bullous pemphigoid, pemphigus, elusive lichen planus, of course, speckled leukoplakia, and erythematous candidosis. So that were my initial clinical differentials. So if we look more closely to this type of lesion, a red lesion which is affecting the palate, so we classify them according to the different categories of the causative or etiology, like traumatic
Dr. Iqbal, we have lost your voice and your video.
Hello.
Yes, you can go on.
Okay, so I classify them into different categories according to the etiology, like traumatic lesion, infective lesions, and we have idiopathic or inflammatory lesions, which included erosive lichen planus, pemphigoid, pemphigus, and lupus. And there are also more aggressive type of lesion like erythroleukoplakia, speckled leukoplakia, which is called squamous cell carcinoma also, and Kaposi's sarcoma also sometimes present to the similar type of lesions. So biopsy was mandatory, and I did a biopsy which showed typical features of lichen planus, like sawtooth ridges and band-like infiltration of the lymphocytes and severity body formations, which is typical for a lichen planus lesion. And there is a complete detailed report of the histopathology, which shows similar to the final diagnosis of lichen planus. And clinically, that is the like a erosive type of lichen planus, which is my diagnosis. Erosive lichen planus is has malignant potential also, so we should be very careful in management of this type of lesions. This is the histological features of the initial biopsy report, which shows the diagnosis of the lichen planus. It has typical feature of the lichen planus. My goal was to management of the lesion, which is sometimes become very difficult. Initially, I started with the topical prednisolone as a mouthwash. And it continued with the oral hygiene management and mouthwash and everything for 3 months, but it was not very effective. and what was not controlling the pain and symptom of the patients. Then I started oral prednisolone
Dr.
to
Iqbal,
control
I'm sorry, your time is up.
my time. Few
Yes, your
slides more.
time is up.
Okay, thank you.
Okay.
Should I continue?
No, actually, I guess.
I will show you the just final image and then it will be. So I started with systemic prednisolone therapy, and it shows marked improvement in the lesion, and it showed that now lesion is improving and there is a reduction in the size and patient also feeling good. But I saw these vesicles on the soft palate, and I should want to keep patient and follow up, which is very important in the management. Thank you all for hearing me. This was a very nice session. All of you are wonderful and very nice to me. Thank you very much.
Thank you so much. Okay, our next presenter is Dr. Usha Hagde.
Yeah, just a moment. I'll just share my video
Yes.
screen. Okay. Good evening to all. First of all, I want to introduce myself, Dr. Usha Hegde, a practitioner practicing oral pathologist passionately for the past 25 plus years. So I'm not here to compete for the rising star, rather to drive in some message to the rising stars, which they need to practice in the clinical practice as well as in their histopathology practice. So this is a case of a female patient, 13-year-old patient who came to us with a swelling on the left side of the face 1 year back, and with no history of pain, and intraoral examination revealed a retained second molar on that side with obliteration of the buccal vestibule. And the radiographic examination through OPG revealed a well-defined unilocular homogeneous radiolucency and a nice sclerotic border with the resorption of the teeth in that area, as well as an impacted tooth which was driven to the almost to the inferior border of the mandible with incomplete root formation. Teeth vitality in this area, all the teeth are vital, and the aspirate showed a straw-colored fluid with cholesterol crystals, and the biochemical analysis revealed a high protein of 8 grams per deciliter. A provisional clinical diagnosis after correlating with the radiological findings was that of dentigerous cyst associated with impacted 3-5, and a treatment was planned for enucleation with extraction of 3-5 under LA. However, we lost the patient. The patient did not turn back for almost 18 months, and she came back to us after, 8 months, and she came back to us after 8 months, wherein she had mild pain. The swelling size had increased, and there was further expansion of the buccal cortical plate, and almost complete obliteration of the buccal vestibule intraorally. We extracted the deciduous tooth which was still present, and a comparison of the first visit and the second visit radiographs revealed an enlargement or increase in size of the lesion, with the tooth being further pushed down to the inferior border, more resorption of the associated teeth. So it was a progressive lesion. CT scan was advised, and the CT scan revealed the extent of the lesion with an intact lingual border and an expanding buccal cortical plate. 3D reconstruction also revealed the extension of the lesion involving 3334 and C6. An incisional biopsy was performed, and the findings revealed under HND stain sections was that of an infected dentigerous cyst with a nice reduced enamel-like epithelium with an infected connective tissue capsule. So treatment to planned for this particular case was a surgical treatment of the cyst with extraction of 3-3, 3-4, 3-6 and impacted 3-5. Once the lesion healed, it was planned to replace the extracted teeth with prosthesis and follow up with a regular follow-up. The surgical excision and peripheral corticotomy was performed, and the excision biopsy was sent for histopathological examination. PRP was placed in the site of the surgery, and the sutures wound was closed with the sutures using Vicryl suture, 3.0 Vicryl suture. in the histopathology lab, a thorough examination of the complete excision mass was done. And this revealed areas where it satisfied VG criteria, the epithelial lining showing VG criteria. And also this lining was proliferating into the lumen as well as proliferations within the lining, the cyst lining was seen. So based on these findings, a final diagnosis of unicystic ameloblastoma type 1.2 was given. Now, since the incisional biopsy was given as dentigerous cyst, only surgical treatment was done. But however, after informing the surgeon that it was suggestive of an unicystic ameloblastoma, the surgeon opened up the site and further treated with carnoid solution after the excisional biopsy report. Now, literature has shown that just surgical treatment with curettage or enucleation, the recurrences are high. However, when treated with carnoid solution, the recurrences are lower. Hence, one needs to modify the treatment plan after the complete excisional biopsy specimen examination too. The post of follow-up has been uneventful. The patient has had no recurrence even after 12 months. So one should view, when we are viewing dentigerous cyst, one should view it as a potential for ameloblastoma origin and graded as a pre-ameloblastoma lesion, since ameloblastomas show at least 15 to 30% of these ameloblastomas are seen to arise from the walls of the dentigerous cyst. And when an excisional biopsy concludes a diagnosis of a unicystic ameloblastoma rather than a dentigerous cyst, and additional treatment with use of cornoid solution is recommended since chances of recurrence is low. So the take-home message to all the budding clinicians would be, first of all, a thorough clinical and radiographic examination and their correlation is very important in narrowing the diagnosis. Histopathology is the gold standard in establishing final diagnosis in most cases, and examination of complete excised mass by a single pathologist. I'm stressing the single pathologist because in most of our institutions, the surgeons have the habit of sending out one piece to one pathologist and then another biopsy bit to another pathologist, and the whole whole specimen cannot be viewed by single pathologist. So the diagnosis will vary. So I repeat, examination of complete excised mass by single pathologist is very important, as incisional biopsy might not represent the whole pathology. And finally, there should be a good coordination between the clinician, pathologist, and the surgeon, since many a times treatment plan needs to be altered after the incisional or after the excisional biopsy examinations. So to drive home, multidisciplinary approach in treating such pathologies is very, very important. Thank you.
Thank you, Dr. Hegde. Yes, that was also an interesting presentation. We go on to our next presenter, Dr. Arushi Pandey. Yes, although your volume is very low, but you're audible.
Okay. Hello. Good afternoon, everybody. I'm Dr. Arushi Pandey, and I'm a practicing oral pathologist from Kota, Rajasthan. Now, let us start with the presentation. I will be elaborating the differences between two benign fibro-osseous lesions that are ossifying fibroma and fibrous dysplasia. Now, both have always posed a dilemma for pathologists because of their overlapping histopathological picture. Now, what is the aim of my presentation? The picture says it all. Master the basics. My presentation is in two parts. Firstly, I will list the basic differences between ossifying fibroma and fibrous dysplasia. And in the second part, we would see the case which is dealing with ossifying fibroma. So let us quickly scroll through the basic differences, starting with the clinical features. Now, if you see difference between ossifying fibroma and fibrous dysplasia, ossifying fibroma generally occurs in third to fourth decade of life, whereas fibrous dysplasia occurs more early within third decade of life. Now, more are both of them are more female oriented. That means females are affected. Site for ossifying fibroma B is the mandible. While for fibrous dysplasia, the monoostotic type, the maxilla is affected more, and the polyostotic type, the upper limbs are affected, and the jaws are spared in polyostotic, generally spared. Coming to the radiographic features, which are very classic, ossifying fibroma is very well defined. It has a sclerotic border of 1 millimeter. Sorry, not sclerotic, it has a sclerotic border, and beneath the sclerotic border, we have a 1 millimeter radiolucent halo, which corresponds to the capsule of the lesion. Now, this may contain radio-opaque foci, and resorption of the tooth present within the lesion show there is resorption of the tooth present within the lesions. Whereas in fibrous dysplasia, the borders are very ill-defined. You cannot see the difference between the lesional bone and the normal bone, and hence the name ground glass or orange peel appearance. Now, the resorption of the tooth present within the lesions is generally absent. Coming to the gross specimen, ossifying fibroma is very well demarcated. It is easily enucleated, just like a tennis ball coming out of the bone. And when we do the grossing, we see the glistening white capsule. And as we get through, we have the gritty feel. While in fibrous dysplasia, since it is not demarcated, it comes out in tiny bits and pieces. Now, the color is light gray to grayish brown. And if you see the block, the small pieces look like decalcified bone. Finally, we come to the histopathology. Ossifying fibroma has a capsule, which is definitely absent in fibrous dysplasia. Ossifying fibroma is more fibrocellular as compared to fibrous dysplasia. Now, ossifying fibroma is composed basically of cementum-like material, which are known as cementicles or samoma bodies, depending on the subtype of your ossifying fibroma. Whereas the fibrous dysplasia is mainly composed of delicate woven trabecular bone, which are in your Chinese letter pattern. There is a definite osteoblastic rimming present in ossifying fibroma, which is absent in the fibrous dysplasia cases. Now, with these basic outline in different in between the lesions, we'll see the case. It was a case of a 33-year-old female, and she had a chief complaint of swelling in the face, which had grown over a period of few months. And now she had even started complaining of slight tenderness, and there was a obvious deformity seen both in the maxilla and in the mandible. Now, if you see the OPG, now this OPG is very striking. All the quadrants of the maxilla and the mandible, all four, you can see these well demarcated lesions, and they are all seen in the molar region. The mandible ones are very clear with the sclerotic border and the radiolucent areas between, within the lesion. The surgeon told that this lesion came out very easily from the adjoining bone, and it had a capsule which was glistening white, and we performed the histopathology. Starting with the outer portion of the tissue, we could see a very nice fibrous capsule lying just beneath the cortical bone. Going deeper into the lesion, we could see the cementical chunks which are lying in the fibrocellular dense stroma. Now, if you go into a little higher view, here, this is a view of a cementicle, and you can very nicely see around this cementicle, the brush borders, which are actually the Sharpie's fibers of the cementum. And you can see the osteoblastic rimming there, as well as how fibrocellular dense the stroma is. Now, with all these features, we came to a final diagnosis that this was a case of ossifying fibroma. Now, the rarity of the case was that it was multiple. So we had to go another step further to find out whether how did this occur, whether it was a sporadic case or was it associated with a syndrome. And we carried out further investigations, and we found that the parathyroid hormone level of the patient was drastically high. And apart from that, the patient gave a history of 4 operations for removal of uterine fibroids. Now, keeping all this in mind, we finally diagnosed the case of hyperparathyroid jaw tumor syndrome. Now, this is a very rare case, 3rd reported case of the condition. And at the end, I would like to say that Jankar bano, because only what your mind knows, your eyes see. Thank you.
Thank you, Dr. Rishi. Yes, we are having a very nice range of presentations, I must say. Okay, next presenter is Dr. Srishaila HS. Reminding everyone again to please vote using the link given in the chat.
Yes, good evening, everyone. Myself, Dr. Sri Shaila, faculty in JSS Dental College, will be presenting on the topic liquid-based cytology, the technical advancement in oral cytology. Okay, all of us as diagnosticians are aware of the drawbacks associated with exfoliative cytology, which sets it back as an ideal diagnostic tool. So the result of search for a better improved cytological technique is LBC, which is in use since 1990s. So what is LBC? It is basically the collection of cellular material into a vial of preservative fluid. Unlike the conventional cytology, the sample, instead of being spread onto a glass slide and fixed, the sample here is suspended in a vial of liquid preservative, processed to break the clot and remove the debris, and then the cell pellet, which is obtained, is placed and spread onto the glass slide to obtain a thin monolayer of cells with a clear background. And in the LPC, unlike the conventional cytology, we also get increased quantity of cells, which will be very useful for better diagnosis. Going to the technology per se, the instruments which are used in LPC are similar to the one used in conventional, that is the spatulas, either plastic or metal, cytobrushes, oral CDX brush, or the cotton swab. And once the sample is obtained using the sampling techniques, it is transferred to a fluid containing bottle or a vial, which is an alcohol-based preservative. So once it is into the vial, all the cell suspensions are completely transferred into the vial, and it is placed into a machine, which is automated machine. And under this, it mechanically processes the sample to provide the slide, which is for the pathologist to diagnose. So the process is basically the sample is collected, it is transported into a transport fluid, which is vertexed using a density gradient centrifugation, loaded onto a auto prep robot, which can handle multiple samples. Then it is transferred to a settling chamber. The cells sediment under the gravity to form a thin layer on the slide. So during the processing, we use a clearing solution, which will remove the obscuring material, mucus in the blood, and the density gradient centrifugation separates the cell according to the specific weight. So the cells like granulocytes, erythrocytes, even the debris, because of their lower weight than the epithelial cell, they accumulate above the density gradient, which are discarded, and the pellicle which is formed is admixed with a cellular base solution, and then it is finally transferred to the glass slide. So there are three key phases which are involved in this process. The dispersion phase, there's a production of randomized cell suspension, breaking up the cell clumps and mucus. In the cell collection phase, a negative pressure pulse is produced, which draws the fluid through the filter, trapping a layer of cellular material. In the cell transfer, the cellular material which is present on the filter is transferred onto the glass slide. But in LPC, once the material is transferred into the glass slide, the remaining material can be deposited back into the vial, which contains the fixative. So this is the diagrammatic representation of the three key phases involved in the machine. In LPC, the collected sample can be processed by two methods. One is a direct to vial method, wherein the sample is directly used for the LBC procedure. A split sample method, wherein the sample is used both for the conventional cytology as well as for the LBC. Going for the commercial ways, there are 3 to 5 technologies available for the LBC based machines. Only 2 of them, that is the ThinPrep and SurePath, are FDA approved, whereas the other techniques like Cytoscreen, PapSpin, and Labanod EasyPrep are not approved by FDA. Even the computer-guided imaging systems are available, which helps in increased detection compared to the manual methods. So this is the diagrammatic representation, which shows that the thin smear layer is better than that of the conventional, as well as the clear background is better than the conventional, which provides a better diagnostic capability. The material which is stored can also be used in the future for multiple assays, including the HPV typing and genomic assays. So we can say LBC produces a more representative sample of the specimen with reduced obscuring material, which allows faster and reliable screening by the pathologist. So to conclude, greater disease detection is possible with LBC with improved lab efficiency. Thank you, all of you. Thank you, ma'am.
Thank you, Dr. Srishaila. So next is Dr. Gauri S. Panchanavar.
Very good afternoon to one and all. Myself, Dr. Gauri S. Panchanava, lecturer from the Department of Oral and Maxillofacial Pathology, D.A. Pandu Memorial Lab Dental College, Bengaluru. Today I'm going to speak about epithelial mesenchymal transition. So let us go into the details of molecular aspects of a common malignancy associated with the oral cavity. As we all know, cancer development is a multi-step process which occurs because of accumulation of genetic defects and mutations which are seen at the molecular level. These changes at the molecular level are even evident before any changes noted in clinical as well as histopathology. Detection of these changes will lead to early diagnosis of high-risk lesions. There are various molecular mechanisms and pathways that regulate cancer development as well as progression. One among them is epithelial mesenchymal transition, which contributes to the tumor progression and metastasis. It's a multi-step morphogenetic process that enables the cancer cells to break through from the primary tumor site and migrate into distant organs, leading to metastasis. It is a reversible biological process that occurs throughout the embryogenesis as well as organ development. This was first described by Elizabeth Hay in the year 1968, wherein he developed a chip primitive streak formation model, which was used to demonstrate EMT. Initially, the term used was epithelial mesenchymal transformation. Later, this term transformation was replaced with transition at the first meeting of EMT International Association in Australia 2003. The term transition refers to reversibility of a process as compared to transformation, which is irreversible phenomenon. In EMT, epithelial cells lose their cell polarity and cell-to-cell adhesion and gain the migratory as well as invasive properties, acquiring mesenchymal stem cell properties. As we all know, epithelial cells are attached to each other by means of intercellular junctions like tight junction, adherent junction, and gap junction, thus form a coherent group of cells. They also have a basal polarity with the basement membrane that separates the epithelium from underlying connective tissue. And these epithelial cells will lack ability to migrate and invade. And on the other hand, mesenchymal cells have got a spindle-shaped morphology. They lack intercellular junction and polarization, and also they interact through focal points. They commonly seen singly and have got ability to migrate. Thus, EMT involves formation of motile cells from non-motile epithelial cells. So based on the biological context, EMT are of three types. Type 1, where we see in development embryogenesis. Type 2, where we see in EMT in chronic wound healing and fibrosis. Type 3, in malignancy. EMT in embryogenesis, from the generation of single-layered creatures to multi-layered species, EMT is engaged in embryogenesis as well as organ development. Basically, EMT allows the neural crest cells to come out of the ectodermal layer and reach the distant places to form new organs. Whereas EMT in wound healing plays an important role also in tissue regeneration. Myofibroblasts, which are essential for remodeling of the maturation phase of wound healing, are primarily formed by local epithelial cells that have undergone epithelial mesenchymal transition. And any dysregulation in EMT process during wound healing will lead to fibrosis of organs. So in cancer, it has been linked to emergence of metastasis, high rate of recurrence, and shorter survival time. And these neoplastic cells will exhibit genes that promote proliferation and tumor formation. It acts as a multi-step morphogenetic process that enables the malignant cells to invade into the deeper tissues and migrate into distant organs. Thus, EMT promotes metastasis and tumor invasion. It involves loss of cell adhesion, change in the polarity of the epithelial cells, and acquisition of spindle-shaped morphology. Thereby, polarized epithelial cell will transform into highly motile mesenchymal cell. These are the various pathways that regulate EMT and various transcription factors that are involved in EMT process. There will be decrease in the expression of epithelial markers such as E-cadherin, desmoglein, cytokinin, whereas there will be increase in expression of mesenchymal markers like vimentin, N-cadherin, fibronectin in EMT. So to conclude, EMT plays a crucial role in carcinogenesis, and its early detection through various marker expression is of utmost importance to prevent tumor progression as well as metastasis. Thank you, one and all.
Thank you, Dr. Gauri, for a nice presentation. We have come to our last presenter, Dr. Anita Florence. Dr. Anita, you can share your screen.
Yes. Good evening, one and all. Oral cancer and pre-cancer, to screen or not to screen. This is the topic I'm going to talk about today. I'm Dr. Anita. When we talk oral cancer, it is oral squamous cell carcinoma. And the reason why the early stages are missed out is oral cancer has very subtle and multiple presentations. Almost 95% of oral cancers are oral squamous cell carcinomas. It is the 6th most common malignancy worldwide, and its 5-year survival rate is still about 50%, which is enormous. And cancer starts with no pain and ends in pain. It can be anything from a normal cheek ulcer to a white patch with or without discomfort. So what are precancers? Oral potentially malignant disorders can be anything in this list. They can be diseases or conditions. But more common white lesions, which resemble like precancer or leukoplakia, can be frictional keratosis, tobacco pouch keratosis, cheek bite, and linea alba. These things can be clarified by giving a gap of 2 weeks period for removal of the causative source of irritation. And some benign tobacco-related reactive lesions also have to be considered here. Smoker's melanosis and smoker's palate are not oral cancer or pre-cancer. So what is the why of oral pre-cancer and cancer? We have known risk factors like tobacco, alcohol, areca nut, betel quid, and certain infections like candida, human papilloma virus, etc., dietary habits, and even genetic origin. So OPMD can become normal, or it can be unchanged, or it can undergo malignant change. So what happens next? So why early detection matters? Because more than 40% of cancers are preventable. They have good prognosis. They have improved survival rate, and they can downstage the disease. We have previous studies in our own country, which is giving all these support to these evidence. Does OSCC arise de novo? Yes, the answer is yes. Both OSCC de novo and sequential lesion are having bad prognosis as each other. What about oral tongue and oropharyngeal cancers? Now, in the past decade, there is increase in oral and base of tongue squamous cell carcinoma, particularly in women and younger patients without the traditional risk factors of alcohol or tobacco use. So from this, early detection and referral matters. So what do we do for that? What is the molecular basis of carcinogenesis? The epithelial cells harbor not merely a collection of mutations, they undergo molecular alterations even before the tissue level histological changes are evident. So to screen or not to screen, it is both, we have to consider both harmful and the beneficial effects. So what we can do is routine oral clinical evaluation followed by the gold standard, which is biopsy and histopathological assessment. And adjunctive agents can help in cases, starting from toluidine blue, lugolzidine, methylene blue, acetic acid, and rose bengal stain. And while recording the findings of the cancer screening,
the oral cavity map can be used. The adjunctive equipments are three types based on tissue reflectance, tissue autofluorescence, and optical or light-based. The light-based techniques have an advantage of non-invasive and intact at cellular level results we can get. For example, optical coherence tomography. All these are at the study research level. Oral brush cytology. This is a well-accepted, minimally invasive technique for screening for oral cancer. It yields a computer-assisted analysis, leading to the next era in pathology, which is digital pathology. And as general dental practitioners, we can practice all the types of biopsies, especially microbiopsy, a novel method, which can be done with the use of a dermatological ring curette. So what are the hurdles in oral cancer screening? There is risk of overdiagnosis. There is a need for training of the screeners, who can be general dentist or primary healthcare professional, need not be only a dental health professional alone. Compliance, the screening tools, and the cost. So research, the future of screening is that biomarkers are introduced.
Dr. Florence, we are out of time.
So the future has to be kept in mind. Mouth self-examination can be used, and telemedicine has its role in diagnosis and screening of oral cancer and pre-cancer. So it's every dentist can perform by accelerating the referral and tobacco cessation advice. And this will set the balance right. Thank you for your patient listening. Thank you, one and all.
Thank you for the presentation, and thank you for everyone's presentations. Now I request everyone to put on their cameras so we see everybody. Yes. We have a few comments here. I will just tell you all about those. First and foremost, to remind our audience again, I can see some people saying I vote for different contestants, but you can't vote here. This vote will not be counted. You have to vote on the website, the link that is given, because that's a survey. You have to vote there. Only then it will be registered. So follow that link and go there and vote. Right. So that's the first thing. The second thing is we had some comments. Everyone is happy with the content. Professor Hilla has a comment. One is, the first one was for our first contestant, that was Dr. Sonal, and he would like to connect with you. So I will help with that so you can connect. The next comment was some comments about the cases that were presented. I suggest everyone go afterwards and read the comments so you know what are the suggestions coming in about your cases. Otherwise, it's been a great set of presentations. It's been so nice to have everybody here. And I think I'll give a few minutes to our two judges to say what they thought. I'll start with Dr. Bhuvan. Yes, what would you like to say?
Good evening, ma'am. No, really, the presentations were extraordinary and quite thought-provoking. It was a blend of different niche areas, ma'am, which I can say. From ranging from oral cancer to odontogenic cysts to odontogenic tumors and to the orofacial pain, and from a general dentist point of view as well as from oral pathologist point of view. So I must congratulate every presenter that they have done really a good job, and please keep it up. Congratulations to all.
So very true. Dr. Yoeta?
Hi, ma'am. And hi, everyone. Congratulations for participating in this event, because it's a perfect platform to speak your heart and speak your mind. So to come out of your shell and opening up into the public platform. And like there are so many topics, as Bhuvan mentioned, different topics, right? So it was like a learning session even for us. It started with cognitive behavioral therapy and practice how to
Practice.
do a practice management, oral pathology, other side of the coin. We always try to flip out, then role of women's in HIV, tongue
Yes.
ulcers, which is like a need of the hour. And as usual, my favorite topic, two ameloblastomas.
I was thinking the same only.
And lichen planners, fibrosis lesion, liquid-based cytology, EMT, OPMDs, what else? Like
It
varieties,
was
varieties.
actually a potpourri of cases, ma'am.
Yes, yes.
Yes, it was.
And everyone did a very good job, and I'm sure like this oral pathology 360 is expanding. Few of the international participants also are there.
Yes.
So I'm so happy, and I should congratulate once again Mandana ma'am for this great initiative and giving me the opportunity also. And I'm so happy to be with Dr. Bhuvan and among all the participants today. Thank you. And winning or losing, it doesn't matter. So participation, we it is a perfect platform to reach everyone. So that is what is always meant to be. And best wishes each and everyone, and thank you ma'am once again for the opportunity.
Thank you so much. Thank you both for putting your time, your efforts, and I know from your very busy activities. And yes, when the ameloblastomas were coming up, even I was thinking of you, Yotap. And that's exactly what we are looking for, is besides having this where we have a mix of presentations.
Yes.
Frankly, what my dream is that we have more and more topic experts among us within the dental fraternity, whether it is within oral pathology or oral medicine or oral surgery or any field where we have experts, the where we have globally renowned experts among us. And that's not going to happen overnight. It's, someone with a topic all the time. And in years to come, we will be there. And that's what I'm looking for. So let me ask the contestants, anyone would like to say anything? You can raise your hand if you want to say anything. I can see you, I guess. Yes, Dr. Akinshipo.
Yeah.
Yes.
So I've been participating on such a platform after a long time. First of all, thank you for this. I thoroughly enjoyed preparing and presenting. And as always, I still want to drive home the message. Don't forget your basics, and have a very open mind, open discussion with the clinicians. That's very, very important in the present day practice.
Yes. I have to say, it was nice meeting you after a very long time.
Yeah.
We, of course, are almost contemporaries. So I have known Dr. Usha Hegde for a long time. Yes. Yes, Dr. Akinshipo, you wanted to say something.
Well, I just wanted to say thank you for providing this platform to express ourselves. I am particularly delighted about your vision about this program, the Open Mic program, whereby you allow international audience and international faculty to come together and say something about their practice and their interest and what they've been doing. As you can see, I don't think we're that many from this part of my world on this platform. So I tend to see my connection with your channel in particular, because I really like the channel as something that will make me grow. And so I made it a point of duty to be part of this today. So just want to say thank you once again for providing the channel. And I thoroughly enjoyed
Thank you so much. Dr. Akinshipo was representing Africa, and Professor Joss has also commented on that. So,
Just want to
yes,
add
nice.
on, Dr.
Dr.
Bhuvan
Usha?
was my student. I'm very
Yes.
happy and proud to see Bhuvan progress so much.
Thank you so much,
I must
ma'am.
have taught him
Yes.
well, so he's reached great levels.
Yes.
Thank you so much.
We have Dr. Gauri. I think Panchanawar would like to say something. I can't see. Dr. Panchanawar?
Yes, ma'am. Thank you so much for giving this opportunity to present on this platform for a young budding oral pathologist like me. Thank you so much, ma'am.
You're most welcome. Right. So,
Thank you,
anyone
ma'am,
else?
for providing this scientific platform. And it's a pleasure every time to connect with you and 360 Oral Pathology. It's so many different ideas we get to hear from our colleagues, from our seniors, from students. It's really very, very interesting. And it always keeps on adding something to our knowledge and definitely inspires us to read more about oral pathology as well as general dentistry. And thank you so much, ma'am, for having this platform here and giving me this opportunity to be a part of it. Thank you, ma'am.
You're most welcome. And I have to mention to everybody, Dr. Swapna has already presented a lecture on the platform on OP Tuesdays, which you can go and listen to. It's a very interesting lecture, actually. So, you know what I have to say, it's really not about me at all. It is, yes, about oral pathology 360, but oral pathology 360 is so much beyond me. It is every one of you. It is everyone who has done so much. Every single weekly presentation, there are over 250. I think we are now coming close to 300. I've been saying 250 for the longest time, not adding the number. But it is every single person who supports our events, who takes part. And it is everybody. It's not just me. And I'm so happy that you all were here, and you have also, every one of you in your own way, I must say, contributed to the movement that oral pathology 360 is. And thank you so much. Yes, Dr. Sonal wants to say something.
Hello, ma'am, and thank you for giving me this platform. Orofacial pain practice or CBT practice is still new. In fact, believe me, every one of us is doing it, but we need more and more platform for presenting our cases. And thank you for providing me with this platform. It was wonderful, and it was really wonderful to go back to my old college days, listening to pathology, oral pathology, and all. Because for us, clinical practitioners, general practitioners, this becomes like just referral cases. Like we just refer them, and we are done with it. So thank you for brushing up my knowledge, and I'm sure I'll be more vigilant now. As well as hopefully my CBT lecture has incorporated some or the other points for you guys also to take home. So thank you so much for this big and wonderful platform. Thank you, judges. Thank you, everybody.
Thank you so much. Dr. Arushi, I think, wanted to say something. I seem to have lost her. Dr. Arushi?
Ma'am, can you hear me?
Yes, I can hear you, although I cannot see you, but I can hear you.
No,
Now I
actually,
can
we
see
have
you.
lots of rains here. We have lots of rain. We have a red alert here, and our connection is very poor. But thankfully, I could present. And thank you, ma'am, for the opportunity.
You're most welcome. Yes. So I think we have, Dr. Bhuvan wants to say something. Yes.
Ma'am, I think I want to give some closing remarks.
Okay.
I just want to acknowledge ma'am's work, Dr. Mandana ma'am's work. Actually, ma'am's work is like a mordant. If we talk in oral pathology language, so she is acting as a mordant between the oral pathologist and the listening community. So thank you so much, ma'am, for giving such a platform which was not so available during the previous era, and it will definitely democratize the challenge of like coming up. So it is in a way helping everyone to come up and giving. And yeah, I also debut with your channel only. What should I say? So thank you so much.
Yes. Dr. Yoita, you also want some closing
Yes, ma'am.
remarks?
Yes. As usual, you have done a perfect job of joining the pearls, and you are just a golden thread, ma'am. No words to say. The choosing of your word, your patience, the way you handle people, there are a lot more to learn from you. Thank you.
Thank you so much. I am truly humbled by all of you all. Thank you so much. Thank you. And it has been a pleasure. I'm always so excited when I get to meet more people and when I see so much happening. And today I had one of my ex-students, my very dear Dr. Amit is my student, my ex-student ages ago. He is well grown into his own and does a lot now. But I'm always happy and proud of every one of you, not just him, every one of you. And I do hope you will all do very well. And I do hope you will come back again on the channel soon for different reasons, but it's always there. It's a part of our community. And yes, with that, let's say bye. Remember to keep watching us tomorrow. Watch our channels, and you will see the results. Sometime in the evening tomorrow, somewhere you can find out on WhatsApp, on our WhatsApp channel, or on our Facebook, or Instagram, or LinkedIn, or on YouTube. You know, we are almost there everywhere. You must be getting bored of seeing Oral Pathology 360 wherever you log in. But we will be there and we will bring you this fantastic result of this great contest. Thank you all so much.
Thank you.
Bye.
Thank you, ma'am.
Thank you. Bye.